Sure, we can start.
Okay, sir. Good morning, everyone. Today we'll be discussing about the evidence-based review of acute ischemic stroke. We all know, despite the progress made over the last 20 to 30 years in the stroke, maybe in the form of diagnosis, maybe in the management perspective, stroke is still being the leading cause of disability and mortality. We see a lot of cases coming, and still we see the patients coming out of window period, and probably this made us think to extend the time window. So previously we used to think about the time windows and all. So despite all these progress, it is still the leading cause of disability and mortality. So today I will be discussing about the various aspects of ischemic stroke, the evidence-based review, and let us go through a case scenario before discussing into the evidence. A 45-year-old male, a software professional who is a hypertensive diabetic smoker, presents with sudden onset inability to speak and move the right upper limb and lower limb since 2 hours. So he was last seen normal before going to bed around 2:45 a.m. in the morning. His NIH scoring is around 15/42. His blood pressure is 160/90. His sugars are 110, and initial CT brain was done. It is normal. So this is the case scenario. And given the case scenario, so what would be the next option? So what is the next step in the management? Is it IV thrombolysis? Will you go ahead with IV thrombolysis, or take this patient for a mechanical thrombectomy? IV thrombolysis followed by mechanical thrombectomy, and none of the above, as the patient has high risk of intracranial bleed. So regularly, day in and around, we get such cases who present with a wake-up stroke. So it is still a dilemma whether which therapy to be adapted, how to proceed. So today I'll be discussing about the approach to ischemic stroke. What is the role of thrombolysis in acute stroke? What are the recent advances that have been taken place in the last few years regarding the endovascular therapy, the general intensive care management of an acute ischemic stroke, and some discussion about the malignant MCA infarcts. So coming to the stroke pathway, the moment the patient arrives, the stroke pathway starts from the moment the patient arrives to the ER and identification of stroke in the hospital to till the neuroimaging is done. So it starts with a brief history. When was the patient last seen normal, especially for a wake-up stroke? And if the history is clear cut, like the patient is presenting since weakness and aphasia since last few hours, then it's fine. Otherwise, when the patient was last seen normal is the most important history that we have to consider. It also includes a pre-hospital assessment, that is a Cincinnati pre-hospital stroke scale, to assess for the FAST, the mnemonic, which we call it as a facial droop, arm drift, abnormal speech, and the time of onset of these symptoms. And the Reuser scoring, that is a recognition of stroke in the ER, which includes if the total score is 0, the stroke is more likely. And if the total score is around -1 or -2, the stroke is unlikely. So these are the various pre-hospital assessment scores which we usually adapt to when the patient comes to the emergency. And the next step is the grading of the severity of the stroke using the NIH's scaling. And to exclude the stroke mimics, this is the most important thing which we should consider in patients coming with a weakness. Which this includes hypoglycemia, any seizure episodes, hypertensive encephalopathy can present like a stroke mimic, the mass lesions, the conversion disorder, complicated migraine, all these things mimic stroke symptoms. They usually present with some weakness, they present with some unconsciousness, they present with some aphasia, or any other signs which are similar to the stroke presentation. All these conditions can mimic a stroke. So the moment patient comes to the ER, it's our duty to exclude the stroke mimics, to grade the severity of the stroke after the proper pre-hospital assessment, and then secure an IV access, minimum 18 gauge to be secured. And the first thing to be done is a recording of the blood sugars and as well as the blood pressure. So, and then the getting a neuroimaging done. So this is the basic stroke pathway which we have to follow for each and every patient coming with a acute ischemic stroke. So Coming to the NIH Stroke Scale, it is designed for rating the severity of acute ischemic stroke. It is relatively quick, accurate. It can be done in 5 to 10 minutes, reliable and reproducible. It just requires a speech and language cards and a safety pin to assess the sensory motor weakness. Requires a speech and language cards, but it's a little bit complex grading scale and quantifies the degree of neurological deficits. If the NIH score is less than 4, probably it's a mild stroke, or we have to again exclude the stroke mimics. And if the NIH is more than 15, there is a poor prognosis if treatment is not given. And if it is more than 22, there is an increased risk of intracranial hemorrhage after thrombolysis. So this is the components of NIH stroke scale, the assessment of mental status, cranial nerve examination, and limbs, which includes the loss of consciousness, questions on commands, whether he's following or not, language and neglect, and cranial nerves, visual fields, horizontal gaze, face strength, and dysarthria. These you can find in any of the Google things. And this is the commonly followed NIH stroke scale with instructions and scoring sheet, which is easily available online. You need to ask all these and assess for all these categories inside the to assess the stroke scale. So coming to the most important aspect, that is the neuroimaging. So the main goal of neuroimaging, where we know acute stroke imaging protocols vary among institutions depending on the availability of the infrastructure, depending on the timing, depending on the software and expertise. The main goal of any neuroimaging in acute ischemic stroke is to exclude hemorrhage, to exclude stroke mimics, that is the mass lesions and subdural hemorrhages, to assess the location and degree of brain injury, and see whether the ischemic stroke is of a large vessel is due to large vessel occlusion, to adapt an endovascular therapy, and plus or minus CT angio or a CT perfusion protocol to identify the occluded vessel. So these are the main goals of any neuroimaging in a patient coming with an acute ischemic stroke. So what are the signs which you see in a CT, a plain CT, that is a non-contrast CT? Non-contrast CT is usually the first choice of imaging that has to be done in any patient coming with a weakness. The door to CT time should be less than 25 minutes. The early signs or the subtle signs which we see in a non-contrast CT in a patient with stroke is, the first sign is a loss of gray white matter differentiation. This is the earliest sign. This can present as early as 1 to 2 hours, and followed by sulcal effacement due to the swelling of gyri. And this loss of gray white matter differentiation can lead to the differentiation of basal ganglia with the insular cortex. If you see, there is an obscuration of the basal ganglia and insular cortex, which is usually labeled as a ribbon sign. And if in case of large visual occlusions, you may find some signs like a hyperdense MCA sign or the MCA dot sign, where the hyperdense MCA sign is nothing but when the M1 branch of the MCA is occluded, the large visual occlusion, you can see an hyperdense MCA sign. And MCA dot sign, that is a M2, M3 branch occlusion and a parenchymal hypodensity. If there is an obvious parenchymal hypodensity, probably the age of the infarct is probably around more than 12 hours. So anybody coming with a obvious parenchymal hypodensity on a CT is probably out of the window period, and probably thrombolysis may not help for them. And if a patient coming with a hypertense MCA sign or MCA dot sign, it tells you that only the large vessel occlusion is probably present. And in such patients, you can still think of doing either a thrombolysis or along with the endovascular therapy, depending on the time period. So these are the basic CT signs which one should know about before interpreting patients coming with an acute ischemic stroke. So an association between these subtle signs and poorer prognosis and greater rate of hemorrhagic transformation is also known. So how do you know if CT is a simple CT non-contrast is not sufficient? Is there any other way to increase your findings, to pick up the findings in the early stroke? There is a something called as aspects, that is the Alberta stroke program, early CT score. It's a systematic approach to identify early ischemic changes in the MCA territory. So basically the CT is divided into 10 regions of MCA territory each, and which is allotted each point, and one point is removed from each area. If you see the diagram, the entire MCA territory, whether it's a subcortical region or a cortical region, is divided into 10 regions, and each region is allotted 1 point. And each point is removed from the affected area, and the normal aspect score is around 10. And the aspect score, each area affected, 1 point is removed, and thus the aspect score of less than 5 indicates a poor prognosis. That means more area is involved. And generally, if the aspect score is less than 5, then that means more than 1/3 of the MCA territory is being involved. So, the lower aspect score in the outcomes, people have seen the correlation between the probability of the outcomes and the baseline aspect score. The lower the aspect score, the worse the outcomes, regardless of the thrombolysis, is what they have found. And there is a linear relationship with favorable functional outcome, especially with an aspect score of 6. So, the cutoff of aspect score is probably 6. And anything more than 6 or 7 usually has a good prognosis and a favorable functional outcome when timely intervened. So an aspect score of less than 5 usually has a very poor prognosis, and the probability of hemorrhagic conversion is also high. Then but the thrombolysis should not be withheld based on aspects alone, and very low aspects may be associated with increased risk of spontaneous intracranial hemorrhage. So this is what one have put the hypothesis regarding the CT findings. So coming to the MRI, MRI we all know. MRI is definitely better than the non-contrast CT in terms of picking up an acute ischemic stroke within the window period. And in that, diffuse weighted image is better than any other MRI sequence to identify the lesion. And presence of a visible lesion on the diffusion weighted image and absence of the same visible lesions in the same area on the flare image, that is a diffusion flare mismatch, is predictive of the symptom onset is less than 4.5 hours. That means the age of the stroke is less than 4.5 hours, and still there is a probability that this patient can benefit from a thrombolysis. So there is a very high sensitivity and specificity of MRI for detecting infarcted regions as early as within minutes of symptom onset. So the DWI can also detect relatively small cortical and subcortical lesions, including those in the brainstem and cerebellum, and areas which are not oftenly visualized through the non-contrast CT. So it can also detect small areas, that is which are present, small strokes which are present in the insular cortex, in the subcortical region, in the brainstem as well as cerebellum. So identification of proximal MCA occlusion. So you want probably you have a doubt that there is a MCA dot sign or a hyperintense MCA sign. Probably you can confirm with an MRI, and this can tell you exactly where the occlusion is. The M1 branch or M2 branch or the M3 branch of the MCA is occluded. So MRI is more sensitive than the CT in finding this kind of lesions. Coming to the CT perfusion imaging, we are all fascinated with this kind of imaging nowadays. And what exactly CT perfusion imaging does? CT perfusion imaging distinguishes the irreversibly damaged ischemic core from the potentially salvageable penumbra. Basically, it distinguishes between the core and the penumbra part, and it quantifies how much the ischemic core volume is there and how much the penumbra is there, and what is the potentially salvageable penumbra which is present. And it also gives around the information about the cerebral blood flow and the cerebral blood volume. So basically, the brain is a metabolically active tissue, and it takes around 15 to 20% of the cardiac output. And we all know normal cerebral blood flow is around 55 to 60 ml per minute per 100 grams of the brain tissue. So when the cerebral blood flow falls down below the half than 55, that means around less than 23 ml per minute, this is considered to be the critical level of impairment of function. So when the cerebral blood flow falls to further low, that is less than 10 ml per minute per 100 grams of tissue, then the infarction usually occurs regardless of the duration of the duration of the blood supply. So it is this to understand that ischemic penumbra forms when the cerebral blood flow is too low to maintain the electrical activity. So is it too low to maintain the electrical activity, but sufficient enough to maintain the membrane integrity? So the ischemic penumbra is a potentially salvageable tissue. It is hypoperfused, but structurally intact. The structural integrity is not lost, but still the cerebral blood flow is a little bit low to maintain the electrical activity. and it is at high risk of infarction. And if timely perfusion is not restored, all the current therapies aiming in the stroke are aimed at protecting this tissue. And whereas coming to the ischemic core, the cerebral blood flow is very, very low to maintain the cellular integrity and leading to the loss of ionic pump failure, and cell death occurs within the minutes. So what do you exactly see in the CT perfusion imaging? In the CT perfusion imaging, we see what's happening to the ischemic penumbra. In the ischemic penumbra, there is an increased mean transit time, there is a reduced cerebral blood flow, and there could be a normal or increased cerebral blood volume. Whereas coming to the infarct core, same there is an increased mean transit time, reduced cerebral blood flow, and the reduced cerebral blood volume. The cerebral blood volume also comes down significantly. So in this way, you can both assess the ischemic penumbra and the infarct core. So CT perfusion basically tells you and differentiates between the core size and the infarct volume and the ischemic penumbra, which is potentially salvage. So how do you assess collaterals? We all know that CT perfusion has been done, MRI has been done. Now you have come to a conclusion that there is a significant amount of core and penumbra tissue. And why do you want to assess the collaterals before coming to a conclusion or before starting the therapy? Collaterals are very, very important to know, to basically to have a successful outcomes. Your collaterals also are important. So the moment you see a vessel that is occluded, no matter how much you recanalize or how much you revascularize, it is the collaterals which is the most important independent factor which has an impact on the neurological outcomes. So how do you assess these collaterals? Through MR angiography or a CT angiography. So MR angiography basically each acute ischemic stroke patient has a different collateral status. So this collateral status definitely affects the revascularization and the functional prognosis. So, but there is no uniform recommendation from any guideline whether to choose which sort of imaging, whether it's an MR angiography or a CT angiography. So intracranial MR angiography is performed in combination with a normal MRI brain in the setting of acute ischemia to guide the therapeutic decision making. So if you have a time and if you are thinking there is a complex scenario presenting to you, instead of doing a simple DWA flare images, you can also do the patient. Probably you can thrombolyze the patient and then do an MR angiography to identify what is the collateral status of the patient, whether there is a large acute proximal large vessel occlusions because of which the therapy can differ. You can probably think of doing an endovascular therapy. But this MR angiography may not be reliable in identifying the distal or branch occlusions. And it is also helpful in detecting less common causes of ischemic strokes. For example, young patients, it is not uncommon to see a vertebral artery dissection. Many of the times, vertebral artery dissection is the common cause for a stroke. So in that cases, MR angiography gives you a clear-cut idea what is the etiology of the stroke. Is it a fibromuscular dysplasia? Is it a venous thrombosis? Is it some sort of vasculitis? Is it a arterial dissection? So to know this kind of small but an important things in the etiology, the MR angiography must be performed. So coming to the CT angiography. CT angiography, the collateral circulation can be assessed through CT angiography, and poor collaterals generally correlate with the large infarct size and poor functional outcomes. So the CT angio may identify patients with intracranial stenosis and support the initiation of aggressive medical therapy by choosing either a endovascular therapy or a simple thrombolysis. So mainly CT angiography is done mainly to evaluate the intracranial and extracranial vasculature. What is the advantage of CT angiography over the MR angiography? Yeah, it not only helps in the determination of stroke etiology, but also helps in guiding the treatment. So if you see, it is an excellent in detecting the large vessel occlusions, especially the proximal MCA branches, the internal carotid arteries, the vertebral arteries, the basilar arteries. Many of the times, it is also common where patients come with a basilar artery thrombosis. In such patients, you do a CT perfusion along with a CT angiography and straight away push the patients towards a endovascular therapy. So it is excellent in detecting large vessel occlusions, thereby helping in selection of patients with endovascular therapy. It also provides information about the clot location, the length of the clot, and the permeability. So the sensitivity is as high as 90 to 100%, and the specificity is between 82 to 100% with a positive predictive value of 90 to 100%. Because CT angio provides a static image of vascular anatomy, it is considered to be inferior to the routine conventional angiography or the digital subtraction angiography, because it doesn't provide a dynamic image of the vascular anatomy. It only provides a static image. So it is definitely superior to the carotid Doppler in predicting the high-grade carotid stenosis, or it is helping in dealing with the stenting or an endarterectomy. The only two main drawbacks of the CT angio are increased radiation as well as possibility of contrast-induced nephropathy. So these two things we have to keep in the mind while choosing a CT angiography. But however, many studies are there, and several studies have proved with a large evidence that CT angio does not significantly increase the risk of renal toxicity in stroke patients, even in those with having a pre-existing renal disease, because of the low dose of contrast which we use. And however, neither of these two aspects should be a reason to avoid a CT angiography in stroke patients, since ischemic stroke itself is a medical emergency and a life-threatening disease. It can cause a serious neurological disability. So if you think that the risk versus benefit ratio is definitely low and the benefit is high, probably subjecting a patient to a CT angiography is much better. So not only this point, you also need, before taking a patient for an endovascular therapy or a mechanical thrombectomy, it is very much prudent to see the vasculature, the anatomy of the vasculature, how tortuous your internal carotid artery is, how tortuous your MCA is. Is there any complex lesions inside the brain, complex vascular lesions? It is very much prudent to see these kind of lesions, because once you are taken for a mechanical thrombectomy, you may not actually do the procedure due to the tortuosity of the course of the vessels. So in this way, CT angiography is also very important to be done. So the conclusions of imaging as an intensivist, what is the take-home message regarding the conclusions of imaging? The door to imaging time should not be more than 20 minutes. This is the bottom line. You shouldn't waste much time in doing an imaging. The moment patient comes to you, assess clinically, do an NIH score, and if the NIH score is more than 15, probably, and the CT is showing a large vessel occlusion, it's probably better to do a advanced imaging like a CT perfusion along with an angiography. CT is the initial choice, but MRI is definitely superior to CT for detection of an acute infarct. And CT hyperdense MCA sign should not be used as a criteria to withhold intravenous thrombolysis therapy for patients who otherwise qualify. So the moment you see a hyperdense MCA sign, you shouldn't be panicked that this patient is a contraindication for thrombolysis. It's definitely not a contraindication. Probably you need to further assess what's the large vessel that has been occluded and how are the collaterals, and then choose your therapy. Aspect score is a useful tool. I told you that Alberta scoring system, out of 10, 6 is considered to be the cutoff, and aspects is a useful tool that assesses the early ischemic changes in the MCA stroke and tells about the prognosis and treatment. And as I told, aspect score correlates inversely with the NIH score. The lower the aspect score, the worse the outcomes. The CT perfusion imaging is promising for better patient selection and longer treatment windows. And multimodal CT and MRI, including the perfusion imaging, should not delay the administration of IV alteplase. So for patients who meet the eligibility criteria of endovascular therapy, for example, you know that patient has a large vessel occlusion and you are probably planning endovascular therapy, it is better to do a CT angiography even before waiting for the serum creatinine report, because the benefit is much higher. So in patients who are a potential candidates for mechanical thrombectomy, imaging of the extracranial vasculature, especially the carotid and the vertebral, in addition to the intracranial vasculature, will provide a useful information on patient eligibility and endovascular procedural planning. So you know what's happening to the carotids. Is there any stenosis? Is there any thrombosis? Is there any tortuosity of the vessels in the vertebral artery and the middle cerebral artery? And what gadgets to choose? Is there any inability to access the intracranial vasculature? This helps in assisting or planning the endovascular procedure, knowing much better. So in selected patients with acute ischemic stroke within 6 to 24 hours, who have a large vessel occlusion in anterior circulation, obtaining a CT perfusion, DWMRI, or MRI perfusion is recommended to patient to aid in the patient selection for mechanical thrombectomy. So with the advances in the neuroimaging, so the assessment of collateral circulation is the most important. And the most recent advancement in the neuroimaging one has to definitely think of is the arterial spin labeling MRI. If you have an MRI in your institute and if there is an expertise in interpreting, definitely please go and ask about this arterial spin labeling MRI. The radiologist, you should be asking him whether there is a arterial spin labeling in that MRI. If there is an option of that, it is the most dynamic thing one can do, and it is basically a non-contrast perfusion imaging method to assess the collateral status, and it also provides a dynamic blood flow information, and that is similar that to the obtained of in a conventional DSA. It is like a conventional angiography. So without giving a contrast, without doing an invasive procedure, without puncturing the patient, you can still get the dynamic blood flow images from this arterial spin labeling MRI. So this is the advancement which has been taken place in the recent times, where you can go and ask your radiologist to look at what's happening to the arterial spin labeling MRI and study the dynamic picture of the blood flow information in the collaterals and especially the major vessels of the brain. So all these recent advances in imaging techniques have allowed an extension of this time window for the thrombolysis for patients, especially with the unknown onset of time, especially in the wake-up strokes, and for those with a known onset up to 9 hours. So due to the advances in this imaging, we can still give the option of endovascular treatment or thrombolysis for such patients who come with a stroke, wake-up stroke, or with a onset time more than 9 hours. So the flowchart of neuroimaging, this is the final conclusion. When the moment the patient comes with a stroke of 0 to 6 hours of onset, it is the first thing to do a non-contrast CT or a conventional MRI with a diffusion weighted image and exclude hemorrhage. If there is no hemorrhage and if the onset is less than 3 hours, probably you think of thrombolysis. And if it is 3 to 6 hours of onset, probably you extend the imaging, you add some other imaging to the plain CT or an MRI, either in the form of CT perfusion or a CT angio or an MRI perfusion, and look what happening to the ischemic core with the penumbra ratio. What's happening to the ischemic core, what's happening to the penumbra, and then consider an intra-arterial therapy, like the endovascular therapy or a mechanical thrombectomy. If there is no penumbra, but the thrombus burden is high, probably it may not be helpful, and this can lead to potential dangerous consequences like a hemorrhagic conversion. So coming to the treatment part, the main goal of treatment is restore perfusion, prevent further progression of ischemia. So these are the main goals of treatment. And if you see the timelines, the National Institute of Safety Network, that is a NIND's recommendation timelines in the stroke. The door to doctor time should be less than 10 minutes. Access to a neurological expertise should be 15 minutes. Door to CT completion should be 25 minutes, which has been recently revised to less than 20 minutes. And door to CT interpretation is 45 minutes. This is the time which can lead to delay in the treatment. If you see the door to CT interpretation, they have given us 45 minutes, which is a very huge time. So it is, as an intensivist, it is our job to interpret the CT. The more early and accurately you interpret the CT, you can come down on this time of 45 minutes. So the door to CT interpretation time should be lessened, and door to the treatment, whatever maybe the thrombolysis or endovascular therapy, it should be not more than 60 minutes, and admission to a advanced monitored bed is a less than 3 hours. So if you see these timelines, the recommendation from the ASA or AHA 2019 guidelines is symptom onset to door time should be less than 3 hours, and door to imaging time should not be more than 20 minutes, and door to needle time, that is the thrombolysis, should be less than 60 minutes. That means within 1 hour, the patient should be administered an IV thrombolytic agent, and symptom onset to the needle time, that is from the patient presenting from the symptoms to the to giving the drug, it should be not more than 140 minutes. And door to puncture time, that is the access to thrombectomy centers. If you feel that there is a large vessel occlusion, and if you feel that the patient might benefit from an endovascular therapy or a mechanical thrombectomy, it's very much prudent that you need to refer these patients to thrombectomy centers within 6 hours. So that is a door to puncture time within 6 hours. So coming to the intravenous thrombolysis, there is eligibility criteria. The eligibility criteria. The eligibility criteria is age 18 to 20, 18 to 80 years. You can thrombolyze even a patient till 80 years. Clinical diagnosis of acute stroke within 4 to 4.5 hours of onset. If unknown time of onset and if there is a flare diffusion mismatch, you can still think of thrombolysis in the patient even beyond 4.5 hours. And there should be a measurable neurological deficit in the form of NIH Stroke Scale that is more than 4. And there should be no clear contraindication to thrombolysis. These are the eligibility criteria where you can think of doing a thrombolysis. Exclusion criteria, these are all the exclusion criteria. We all know the exclusion criteria very much. The blood pressure should not be more than 185 by 110. There should not be any active coagulopathy. The blood glucose concentration should be more than 50. And there should not be any recent surgery or an intracranial neoplasm. So should we do any blood test before thrombolysis, and what kind of blood test should we do? So the only thing one should remember is the blood glucose is the only blood test you need to assessment before initiating a thrombolysis in a patient coming with a stroke. So routine checking of platelets, PTN or APTT should not be done unless there is a suspicion of coagulopathy. Many of us tend to wait for the platelets or a PTINR and then start the thrombolysis. So intravenous thrombolysis should not be delayed while waiting for these hematologic results or the coagulation testing results. So the only thing which you need to check is the blood sugars and the blood pressures. If the blood sugars are more than 50, then obviously the stroke mimic of hypoglycemia is ruled out. And if the blood pressures are less than 185 by 110, then probably you can think of thrombolyzing this patient. So routine checking of these hematological parameters is not necessary unless the patient is probably on some form of anticoagulation. Then you need to check these parameters. So the drugs used in thrombolysis, the commonly used drug is altiplase, recombinant tissue plasminogen activator. The dose is 0.9 milligram per kg, 10% of total dosage as bolus in 2 minutes, and the remaining 90% as an infusion over 1 hour. And the maximum dose that can be given is around 90 mg. So tenecteplase has recently been into the study, and now many of the neurologists are choosing tenecteplase because of the ease of administration and the shorter duration of action and the rapid onset of action. It's the dosage is 0.25 milligram per kg as a start dose with a maximum dose of 25 milligrams. So as per the 2019 guidelines, the new recommendation of using tenecteplase as an alternative to altiplase, the efficacy is confirmed through meta-analysis of 5 randomized controlled trials. And all these randomized controlled trials, what they have found was there may not be a favorable functional neurological outcome difference as compared from altiplase, but definitely the bleeding tendency and the ease of administration has chosen this tenecteplase over altiplase. So what is the evidence for thrombolysis? Evidence for thrombolysis comes from basically the age-old studies, that is the ECAS-1 and ECAS-2 trials. These are one of the largest and the first placebo-controlled trials done in acute ischemic stroke patients in 1995 in European countries, which is done across 14 countries in almost 75 hospitals. It's a very large randomized control study, and the eligibility criteria based on the symptoms and the CT scan. There is not on the CT angio. Basically they enrolled all the patients only on symptoms. Any patients coming with a symptoms of stroke within 6 hours, they have enrolled into the study, and they included patients within the 6 hours. And the dose of, if you see the dose of altiplase, the tissue plasminogen activator which they have delivered was way high. It is around 1.1 milligram with an upper dose limit of 100, with varied complications, with more bleeding complications they have seen. Then they performed the ECAS-2, which is a revised one, and the improvised, which is done in 1998. They didn't reduce the time frame. They still enrolled the patient within 6 hours, but altered the dose. They slightly reduced the dose of thrombolytic agent from 1.1 to 0.9, and this resulted in less bleeding complication, but a little bit varied results. So this led to a major another major randomized trial, that is an INTS study group, that is the National Institute of Neurological Disorders and Stroke study group. And this is a study which they have included they have cut down the short time. They included the patients who came with symptoms of stroke within 3 hours. the previous ECAS 1 and 2, they included within 6 hours. This was within 3 hours. And they used a dose of 0.9 milligrams of altiplase with the upper dose limit of 90 mg. And the study outcomes were analyzed in two parts. There is a part 1 and part 2. Part 1 is early improvement. They looked at what's happening to the immediate NIHS improvement of more than 4 points, and the long-term improvement, which they have seen in terms of modified Rankin scale or the Barthel's index. And they found that there is a definitely significant improvement in the overall neurological outcomes. And this comes to the ECAS 3 study. That is the thrombolysis with altiplase within 3 to 4.5 hours after the ischemic stroke. Here, they reduce the time frames compared to the ECAS 1 and 2. The ECAS 3, they reduce the time frame based on the NINT study. They reduce the time frame from 6 hours to 3 to 4.5 hours. And the exclusion criteria included were they didn't include the patients with a NHS score more than 25. If you see the 1 and 2, they just included the patients, any patients who came with a weakness. They didn't grade the scaling. And severe strokes involving more than 1/3 MCA territory, they have excluded. And ECAS 3 was clearly more selective than the NINTS population. So if you see all these trials, there is a little bit of confusion regarding the time frame. So this confusion led whether the patients to enroll within 3 hours, within 4.5 hours, or within 6 hours. This led to confusion. So then this is the major pooled analysis similar to a meta-analysis where they have pooled almost 8 RCTs, including 3,600 patients within 3 hours or 6 hours. This pooled analysis adjusting for number of numbers like age, stroke severity, and irrespective of these things, they were clearly in favor of use of altiplase in the early phase, that is within the 4.5 hours. So then they came to a conclusion, but the outcomes were not statistically significant with the same thrombolytic agents beyond 4.5 hours. So from the pooled analysis of all these 3 trials, the ECAS, the NINTS, and the Epithet and the Atlantis trials, they have come to a conclusion at an arbitrary figure of around 4.5 hours, and then concluded that any patients presenting with a symptom onset of less than 4.5 hours, it is your job to thrombolyze a patient. And these are the subset of patients where they are eligible for a thrombolysis. So what are the recent updates on the thrombolysis? The meta-analysis of 4 major trials were done in 2019, the IST3 trial, the Extend, and the ECAS 4 and the Epithet. And they found that from these 4 major trials on the IV thrombolysis, they studied that if additional CT perfusion imaging was done along with a simple CT or an MRI, it could have better directed the thrombolysis in patient with stroke even after 4.5 hours or patient with a wake-up stroke. And it concluded that patients with salvageable brain tissue on the perfusion scan were more likely to have a better functional outcomes when thrombolyzed. This was the conclusion which these recent trials have given. So this is regarding the IV thrombolysis. Then coming to the endovascular therapy. What about endovascular therapy? We all know endovascular therapy, there is a mechanical thrombectomy device have been used. There is a first generation device and the second generation device. The Mercy device, the Penumbra and the Solitaire are the first generation mechanical thrombectomy device approved by the FDA. And if you see all the studies which have been done with these trials, the Mercy trial and the Penumbra trial, it is the recanalization rates which they have looked at and the neurological outcomes at 90 days in recanalized patients versus non-recanalized patients. And recanalized was achieved reasonably well in around 46% of patients in the group where they have enrolled in the Mercy trial. When I'm coming to the Penumbra trial, the recanalization rates were very high, but if you see the spontaneous intracranial hemorrhage, it is around 11%, that is generally very high, and the mortality was significantly high, around 32%. So this is the studies which have been done with the first generation devices, that is the Mercy and the Penumbra devices. This is a synthesis trial, the IMS3 trial, and the MR rescue trial. If you see all this, there is no major difference in the primary outcomes in terms of the neurological outcomes, whether it's a modified Rankin score or a spontaneous intracranial hemorrhage. There was no significant difference in the outcomes compared with when the thrombectomy was done with these devices. And the IMS3 was stopped due to the futility of the trial. And then came these game changers, that is the stent retrievers. So when you use a little bit uh, uh, modified devices like a stent retrievers, the solitaire and the Trevo devices, the outcomes were much, much better compared to your first generation devices. So these are considered to be the game changers in the endovascular therapy. And if you see these two trials, that is the solitaire trial and the Trevo, which are being published in the Lancet, the solitaire, if you see the successful recannulation rate without any symptomatic intracranial hemorrhage, that is a primary endpoint which I read, it is very significantly high. If you see the recannulation rate for 61%, and in the Mercy trial, it is only the 24%. And the Trevo 2 trial, where they used a stent retriever, Trevo versus the Mercy, they also found that the reperfusion rates were definitely, recannulation rates were definitely high in the Trevo group compared to the Mercy group. And the studies which have been done with these retrievers, the stent retrievers, the MR Clean, Escape, and the Swift Prime trial, the Extend IV, and the Revasc trial, together put as the Hermes group, that is a highly effective reperfusion evaluated in multiple endovascular stroke trials. These are the Hermes group, which consists of 5 trials. All these trials have concluded that definitely the second generation devices are much, much better. So the summary of evidence on the endovascular therapy, the negative trials of the IMS3 synthesis and MR rescue, where they use the first generation device like the Mercy and Penumbra. And the positive trials are these Hermes group of trials, that is the MR Clean, Extend, Escape, and Swift Prime trials, where they use the second generation of the latest device, stent retrievers. So what is the recent evidence on the endovascular therapy? So previously, based on these Hermes trials or the previous trials, endovascular therapy for offered patients who have came beyond 4.5 hours, but up to till the 6 hours limit. But based on this recent evidence, that the Dawn trial and the Diffuse trial, they increase the time duration. Even patients presenting from 6 hours to 24 hours, they enrolled these patients and they subjected these patients to the endovascular therapy and have gained success. So the eligibility criteria for the Dawn trial was a clinical imaging mismatch. They have did the NIH scaling and they did a perfusion mismatch, and they found that these patients who are having a mismatch between the clinical and imaging, they did well with an endovascular therapy even from 6 to 24 hours. Similarly, with the Diffuse 3 trial, the treatment can be started within 6 to 16 hours. So what are the conclusions from the endovascular therapy? Patients eligible for intravenous thrombolysis should receive it even if the endovascular therapy is considered. You know that the patient is presented beyond 4.5 hours, but you still think that probably intravenous thrombolysis is debatable, and this patient can be considered for an endovascular therapy. It is your job to deliver the intravenous thrombolysis along and consider this patient for a endovascular therapy. And the degree of recannulation, the time to recannulation are better with endovascular therapy than with IV thrombolysis. And the newer generation stent retrievers are superior to the older generation one for opening the arteries and possibly improving the outcomes. The only problems with the endovascular therapy is only 10 to 20% of the stroke patients are actually eligible for your endovascular therapy. And the access to thrombectomy centers is also one more problem. And you need to shift the patient to an thrombectomy center within 6 hours, which is probably not truly feasible. And the lack of expertise, probably the interventional specialists who are expertise in performing this mechanical thrombectomy should be present round the clock. And there is something called as futile recannulation. Even after successful recannulation of the occluded vessels, it is not sure that the clinical outcomes will be better. Still, there is something called as futile recannulation. You have recanalized the vessel, you have established the flow, but still the functional outcome may still be poor due to various reasons. So in this case, the endovascular therapy is little bit laborious. Endovascular therapy is more successful, especially for a large vessel occlusion. There is an occlusion of M1 segment of the MCA branch or the basilar artery. And the tissue-based time window can be extended up to 6 to 24 hours based on the recent Dawn and Diffuse 3 trials. So the considerations is the final approach up to ischemic stroke up to 6 hours, you do a CT brain with CT angiogram and probably perform a thrombolysis, intravenous thrombolysis if the patient is coming up to 4.5 hours, and think of mechanical thrombectomy up to 6 hours. And if patient is coming beyond 6 hours, do a MRI with MR angio or a CT angio with a CT perfusion. Assess the ischemic core with the penumbra ratio, what's happening to the tortuosity of the vessels, prepare for the endovascular therapy, and then probably do a mechanical thrombectomy up to 24 hours in selected group of patients. So with advanced neuroimaging techniques and with the advanced endovascular therapy devices, the time window has been increased up to 24 hours. So this is the picture which is showing the time frame. If the time of symptom onset is less than 4.5 to 6 hours, the first choice of imaging is either do a plain CT or a CT angio. The second choice is doing probably an MRI. And evidence-based treatment, intravenous thrombolysis if it is less than 4.5 hours, mechanical thrombectomy till it is around less than 6 hours. And if it is around 4.5 to 24 hours, or if there is an unknown stroke or a wake-up stroke, you probably do a CT angio or an MR angio with a diffusion flare mismatch and probably still think of doing a mechanical thrombectomy. So coming to the routine intensive care management, what we need to do the moment the patient is thrombolyzed or taken up for a mechanical thrombectomy, and then post the procedure, the patient has been shifted to the ICU. It is our job to maintain this early intensive care management, which can make a difference to the patient outcomes. Maintain adequate tissue oxygenation, cardiac monitoring, because MI and arrhythmia are frequently associated with stroke, and it is not uncommon to find an AF along with a stroke. Arrhythmias are frequently associated with insular stroke, so we need a continuous monitoring. And most important thing is to avoid hyperthermia. So hyperthermia has been shown to be neuroprotective in all the experimental and focal, and hypothermia for us is like a neuroprotective measure, which may delay the depletion of energy reserves and which can reduce the oxygen free radical injury. But so far, no major randomized study has been shown to be benefit of this implementing this hypothermia, especially in patients with stroke. And if the hyperthermia is not secondary stroke, probably treat the fever and infections, and there is no evidence of cooling, and potential risks of hypotension, arrhythmias, and pneumonia can happen when you institute this hypothermia in these patients. And hyperglycemia has also been associated with the increased conversion rates. The hemorrhagic conversion rates are increased, especially when there is significant hyperglycemia. So you need to have a strict glycemic control of such patients. And of course, DVT prophylaxis is the general thing. So what about the acute hypertension management? Blood pressure monitoring is very essential. We all know to reduce the blood pressures when we are planning to thrombolyze a patient, and lower and higher blood pressures are associated with an increased infarct volume at 7 days. So what does the AHA guidelines tell you? To lower the blood pressure only if it is more than 220 by 120, or if you are planning a thrombolysis, it's better to lower less than 185 by 110. And how do you do it? The agents preferred are the labetalol, hydralazine, and you should avoid NTG and nitroprusside because they can increase your intracranial pressures. And the goal is 15 to 25% reduction within the first 24 hours. And otherwise, if the patient's blood pressure is less than 180 by 100, so you leave it, and probably this elevation in the blood pressure is probably as a body's compensatory response to maintain the cerebral perfusion pressure and cerebral blood flow to the ischemic penumbra. So when this is a protective compensatory mechanism, you actually don't try to reduce the pressures. So otherwise, withhold all the antihypertensives and still accept the blood pressures if the blood pressures are around 170 or 100. And coming to the malignant MCA infarct, large hemispheric infarctions occur as a sequence of thrombotic or embolic occlusion of a large vessel, that is a distal ICA or the proximal MCA trunk, and also without any sufficient collateral flow. So when there is no sufficient collateral flow and when your large vessel is occluded, it can lead to a malignant MCA infarct. And the carotid artery dissection or the vertebral artery dissection may also lead to such large MCA infarcts. So what is the predictors of the malignant edema? We know there is a large area of brain which is infarcted. And what is the most reliable predictors of edema? The hypodensity more than 50% on the CT, perfusion deficit more than 66% on the CT, is the most reliable predictor, and the stroke volume is greater than 145 ml. If you know the core, the ischemic core volume is more than 145 ml within 14 hours of stroke onset, or 82 ml within 6 hours of onset on the DWA, you know that these patients can go into a malignant edema, and it is very much prudent to monitor them for the raised ICP and plan an early decompressive craniectomy. So coming to the role of decompressive craniectomy, the Decimal, Destiny, and Hamlet trials, see, all clearly favors the decompressive craniectomy, and decompressive craniectomy was statistically superior to non-surgical management for both the primary and second endpoints. And decompressive craniectomy decreases the mortality without increasing the number of severely disabled persons. So the lessons learned from this talk are the take-home messages from this evidence-based review is important predictor for successful recannulation. Any patient who comes with an ischemic stroke, the most important predictors for the successful recannulation are number one, the site of occlusion, the age and composition of the thrombus, and presence of effective collateral circulation. So these are the three important things that determine your successful recannulation, and this can be properly assessed by your neuroimaging. So we need, as an intensivist, we need to have an adequate knowledge regarding the interpretation of a CT or an interpretation of an MRI or a CT perfusion. So it is our job to get a CT done as early as possible within less than 20 minutes and interpret in a proper way to know the site of occlusion, whether it's a large vessel or a small vessel occlusion, and presence of effective collateral circulation. And also, the other important factor for successful recannulation are the timing of thrombolysis, and whether it's a intravenous thrombolysis or whether you adapt a endovascular therapy along with an intravascular thrombolysis. For this, you need a technical expertise and infrastructures. So we need an expertise in interpreting the imaging results. And if centers who don't have the in-house expertise to interpreting the radiology imaging, you can also use the teleradiology, which is recently proposed by the ASA guidelines. And the recent extension of the time window, whether for the endovascular therapy till 24 hours from the evidence which is obtained from the Dawn and Diffuse trials, guided by the core perfusion mismatch through advanced imaging technique, has opened up the possibility that we can include more patients in the coming future for the revascularization category. So by using the proper neuroimaging or an advanced neuroimaging and an advanced endovascular therapy devices and expertise, we can enroll more patients for revascularization, and probably that will change the neurological outcomes. Thank you.
Ghanshyam? Nothing much to add. Thank you, Nandakishore. I think you have very taken through the evidence-based management of ischemic stroke in great detail, covering almost all the aspects.
Thank you, sir.
Okay. So thanks, Kishore. I think stroke management is one area which is seeing a lot of paradigm shifts, and will see a major improvement in the way we are looking at strokes and we are responding to it, especially with the availability of higher capability scanners and of the availability of teleradiology, but most importantly, incorporation of artificial intelligence and machine learning algorithms into the later generation CT scans and MRI machines. That may happen in next 5 years, but there are certain paradigms which have shifted even as we have learned how to manage ischemic stroke for the last 10 years. First point, the concept of last known well or wake up stroke is slowly dwindling away. The decision on thrombolizing a patient is no longer based on the history alone. If the history is reliable and correct, then we may be able to see if the patient is in a window period. But if the window period is not very clear from the historical information, then it is the paradigm and the guidelines, the recommendations, everything seems to suggest an imaging-based decision on thrombolysis versus EVT, that is endovascular therapy. This problem becomes more important is because we don't give up on strokes up to 24 hours. If the patient has a reversible penumbra with a smaller core, then such patients can be first thrombolized and then be subjected to endovascular therapy in the form of thrombectomy or sometimes even a stent place. Now, how do you know whether the penumbra is good, big, and core is small? Traditionally, it has been an MRI diffusion, but again, this is one of the reasons why a lot of patients don't get thrombolysis or definitive therapy for stroke. So, CT perfusion has come in a big way because if it is easy to install a software in a pre-existing CT machine and make the center a stroke center, because CT perfusion can quantify the amount of ischemic penumbra. If the ratio of the ischemic penumbra to core is less than 2, then the benefit of endovascular therapy or thrombolysis is less in such patients. So between 4.5 to 6 hours, there is still a scope for thrombolysis, but between 6 to 24 hours, based on the ratio of the penumbra to the core, you can actually give some definitive therapy to these patients. That's a major paradigm shift in stroke. Second point, do we do primary endovascular therapy like we do for coronary angios, coronary artery disease? Do we forego thrombolysis and do endovascular therapy? This is the consensus. The opinion seems to be no. First, we should offer thrombolysis to every patient who seems to be eligible historically or radiologically for thrombolysis, and then only we go with endovascular therapy. Is endovascular therapy extremely safe and devoid of the hemorrhagic complications of thrombolysis? The answer is no. Even after thrombectomy, even after endovascular therapy, hemorrhagic transformation of big infarcts is known to happen, but the incidence is much less and neurologically significant morbidity will be less with endovascular therapy. The third point we need to understand is whether antiplase is the only drug that is available and what is the current status of tenecteplase. Now, the advantage of tenecteplase is it can be used as a single bolus, as a bolus therapy instead of timing it over a long period of time. It has a shorter half-life and bleeding wise, it seems to be comparable to altitude. So this is an emerging alternative. Tenecteplase can be used for patients with ischemic stroke. Relying on the hyperdense artery sign is not going to be a very. This is another reason why a lot of patients don't get thrombolysis because of the presence of the dense artery sign. Although it is more common in the middle cerebral artery territory, it is also known to happen in the basilar artery territory and the anticirculation. These two territories are not very amenable to mechanical thrombectomy. So we should be more careful of interpreting the dense artery sign in these scenarios. Aspect score, although has been widely used, has some drawbacks. It tends to overestimate the ineligibility of patients for thrombolysis. So, if you are excluding somebody for thrombolysis or mechanical thrombectomy based on the aspect score alone, then as an imaging modality should tell you that there is not much reversible penumbra before you condemn that patient that you are not eligible for any kind of definitive stroke intervention. So these are some of the emerging concepts. Stroke management has changed in the last 10 years, and these are some of the important aspects. So one of the other areas which is equally important and which is equally evolving as we speak is subarachnoid hemorrhage. And a lot of paradigms have shifted and changed in the last 10 years in the management of subarachnoid hemorrhage, and we need to look at the evidence of the management of subarachnoid hemorrhage, like risk assessment, what options do we have, what therapeutic options for vasospasm and other complications, and that is what we will deal next week on the 26th of on Boxing Day, and that will be done by Dr. Harini. So for those of you who have joined us, thank you very much. Please do join us next week. And if you have any queries or comments on this particular session on acute ischemic stroke, please post them on the group from which you got the link to join this webinar. And either the moderators or the speaker himself will answer these queries in the shortest possible time. Thank you very much. Have a good day. Bye-bye.
Thank you, sir.